With that, can I request our next chairpersons, Dr. Akanksha Patriya and Dr. K. Vijayakumar, sir, to take up the reins, please? Dr. Akanksha Patriya is from Surat. She's a practicing endocrinologist. And Dr. Vijayakumar K. is a physician and diabetologist and a PG diploma diabetes from Bengaluru.
Thank you. Thank you for this giving the opportunity to chair this wonderful session from the East Symposium. Well, diabetes, I should first... Very good evening. At the outset, I want to congratulate Diabetes India for an excellent lineup of topics and bringing in the East and the West and making it a wonderful, interesting session all through the 3 days, wonderful agenda. And today, because I am chairing this session, the East Symposium, focusing mainly on the cardiovascular health. In the first talk, I would introduce Dr. Siddharthavan Sangadu. I'm sorry if I'm spelling it wrong, Doctor. Doctor is from Indonesia. His PhD, DTM and H, and he was born in Amsterdam, graduated medical doctor in 1971, and was a specialist in internal medicine and also consultant endocrinologist with a PhD from the University of Indonesia in Jakarta. Currently, he is the professor medicine and endocrinology in the University of Indonesia. He is the president of the Indonesian Diabetes Association for 2 terms and chairman Indonesian Endocrine Society for 2 terms. He also initiated diabetes education programs and organizations in Indonesia. He served 2 terms as executive committee member of the IDF Western Pacific region and presently leading the Indonesian Diabetes Institute and practicing endocrinology at SS Diabetes Care, Pusada Hospital, Silawam Simpatpung Hospital in Jakarta. Well, the topic today would be by Dr. Segundo, the optimizing LDL cholesterol for the cardiovascular risk reduction. As we all know, LDL, low density cholesterol, has been established as a marker for cardiovascular risk. So what is beyond this LDL cholesterol is what, with the real world evidence, Dr. Segundo would be enlightening us in the next 25 minutes. Doctor, please take over.
First of all, thank you very much for the opportunity to talk in this beautiful and important session of Diabetes India. My talk will be, as mentioned, optimizing cardiovascular risk reduction beyond LDL cholesterol. Why should we talk about it? You know that dyslipidemia therapeutics have primarily focused on lowering levels of LDL cholesterol. Lowering LDL cholesterol for reducing CV risk has been a key therapeutic strategy for more than 30 years. And statin therapy, adopted globally, is recommended primarily to lower LDL cholesterol. However, many patients continue to experience CV events despite effective lowering of LDL cholesterol. There are prompted efforts to target additional risk factors to achieve more effective prevention of cardiovascular disease. TG-rich lipoproteins play a causal role in atherosclerosis, highlighting the potential for specific therapeutic lowering. Growing evidence that TGs are not just a marker of increased CV risk, but rather a causal factor that rivals LDL cholesterol. The ASG, they mentioned the unmet need for primary prevention in individuals with hyper-TG not eligible for statins. Targeting patients with hyper-TG with statins or other TG-lowering therapies may be significantly reduce CV events in patients without pre-existing CVD and therefore represents a population that deserves special attention for the primary prevention of coronary heart disease. Statin non-eligible individuals with TGs around 264 milligram per deciliters had risk of ACVD similar to statin-eligible individuals defined according to the 2016 AS guidelines. This illustrates an unmet need for primary prevention, calling for an expansion of guidelines on statin eligibility and the potential for placebo-controlled randomized clinical trials in individuals with hyper-TG. And even the ESG guidelines for 2019, they had a secondary goal. The secondary goal is non-HDL cholesterol. Non-HDL cholesterol evaluation recommended for risk assessment, particularly in people with high TG levels, diabetes mellitus, obesity, and very low LDL cholesterol. Non-HDL cholesterol secondary goals are very high, moderate, and also ApoB secondary goals were mentioned. And after that, there was a study about real world. The real world risk of cardiovascular outcomes associated with TG. It is said that among patients with cardiovascular disease, hyper-TG is common and is associated higher ACVD risk across a range of triglycerides. It is possible that as many as 1 in 4 patients with ACVD may be candidates for emerging therapies. And the large contemporary population-based cohort observed that among individuals with established ACVD, hyper-TG is associated with ACVD events across a spectrum of TG levels. Determined that a sizable proportion of patients with ACVD in the real-world clinical settings have hyper-TG and controlled LDL cholesterol and may potentially be candidates for interventions for further reducing residual cardiovascular risk. The TG reduction in secondary ACVD prevention, the conception as you see here that TG-related ACVD risk is a marker of cardiometabolic risk and insulin resistance associated with obesity, reduced HDL, hypertension, hyper-TG, and diabetes. And this implicates that it is a marker of insulin resistance and cardiometabolic risk. And reduction in TG may indicate reductions in cardiometabolic risk. But it has also direct atherogenic effects of the VLDL, remnant cholesterol, and small dense LDL. The implication of this is that lowering triglycerides may clinically reduce risk of atherosclerosis, and there is a potential therapeutic options with PPAR modulators and omega-3 preparations. The consensus of the ESG about triglyceride lipoproteins and their remnants, the metabolic insights, the role in atherosclerotic cardiovascular disease, and emerging therapeutic strategies. The key point is that changes in VLDL metabolism impact on structure, composition, metabolism, and function of LDL and HDL particles. And hyper-TG favors formation of small dense LDL with potential increased heterogeneity and smaller dense HDL particles with a perturbed lipidome and proteome and effective vasculoprotective function. Although the degree to which these alterations contribute to severe risk is unclear. Formation of TG-rich lipoprotein remnants and their role in atherogenics. In hyper-TG, the overproduction of and inefficient lipolysis of both VLDL overproduction and chylomicron overproduction leads to increased remnant formation. TG-rich lipoprotein remnants contribute to the initiation and progression of atherosclerotic lesions. The particles retention in subendothelial space and followed by inflammation and so on, and it's with a plaque progression. As you see here that the VLDL overproduction and chylomicron overproduction will affect on the atherogenesis. Based on evidence from several sources, particularly preclinical studies, the conclusions were the following. Arterial retention of treated lipoproteins and their remnants is linked to maladaptive responses central to plaque initiation and progression. The ApoE and ApoC3 content of VLDL and high molecular remnant particles is critical to mechanisms of arterial retention. LPL expressed by arterial wall macrophages and smooth muscle cells may directly promote atherogenicis, and cholesterol-rich remnant particles induce macrophage foam cell formation more potently than LDL. Macrophage uptake of remnant particles and native and modified forms elicits an inflammatory response and thereby promoting atherosclerosis. Emerging pathophysiological and metabolic evidence supports the putative heterogeneity of ApoB48 and ApoB100 containing remnants during the postprandial period, with ApoB100 containing particles predominating. And later the same year, the American College of Cardiology has a consensus recommending for providing for clinicians and patients regarding unique aspects of lifestyle interventions for the management of hyper-TG and the use of statins and TG risk based on statin therapies for ASCVD risk reduction, and the following four groups: patients with ASCVD, patients with severe hyper-TG, patients with diabetes, and high-risk primary prevention. Okay. There are four groups. The patient population is, you see here, the patient with ASCVD, adults with ASCVD, and patient with fasting TG more than 150 or non-fasting more than 175, and TG less than 500. And the diabetes also more than 40 years, no ASCVD, and fasting TG more than 150 and non-fasting more than 175, less than 500. And this is the diabetes group. And then this is the other group, the high risk, and this is the patient with severe high TG. All the groups, you see, has the same consideration. You have to evaluate and manage secondary causes, optimize diet and lifestyle intervention for hyper-TG, implement guideline-directed statin therapy and optimize statin adherence still with, and also optimize glycemic control, monitor response to therapy and adherence, and conduct clinical patient discussion for potential benefits, potential harms, and patient preference. If all this is done and it is still fasting hyper-TG, then optional interventions should be considered and risk-based pharmacologic agents could be added. What does the AAC say? The management of ASCVD risk reduction in patients with persistent hyper-TG. The recommendation is that if persistent hyper-TG is defined as a fasting TG level more than 150 after statin use and lifestyle intervention, hyper-TG is responsive to lifestyle modification. Optimizing diet along with regular aerobic exercise can lead to a 20 to 50% reduction in TG levels. So this should always be the first approach. Pharmacology treatment for patients who had established ASCVD and for patients with diabetes, whether or not they have ASCVD, particularly if they are over age of 50 and have persistent fasting TG, 150 and 500, provide LDL lowering therapy first, primarily with statins, and add other LDL lowering medications as indicated. Once maximally tolerated LDL lowering therapy is achieved, or patient's LDL level is at the goal level, if triglycerides are still elevated, then the guidelines of the ACC said it may be reasonable to add icosapent-ethyl to lifestyle modification. One other study in the US of the Kaiser Permanente Reach study, they said that triglyceride levels and residual risk of ASCVD among patients with type 2 diabetes and coronary disease, elevated TG were independently associated with adverse safety outcomes, even after adjustment for clinical and simple biochemical covariates. According to this, after that, there are studies how to mark biomarkers for lipid associated risk with atherosclerotic calcification, the remnants, the LDL, the quantification of lipoprotein-associated risk in ICVD. There is no clear distinction at present between newly secreted VLDL or chylomicrons and their partially lipolyzed products, remnants. These particles are then defined together as triglyceride-rich lipoproteins or remnants. Non-HDL cholesterol is the measured content of all ApoB-containing lipoproteins, that's total cholesterol minus HDL cholesterol. ApoB is the measured concentration of this apolipoprotein in plasma. It includes ApoB100 in all particles and ApoB48 in chylomicrons remnants if they are present. The LDL cholesterol can be measured directly by homogeneous assay, measured after centrifugation, precipitation by the Francis method, or calculated as total cholesterol minus HDL cholesterol minus LDL cholesterol. But the latest effort is that the latest development is to examine or to check the direct remnant assay to measure cholesterol in TRR and IVL particles, and also LPA cholesterol assay. The newest approach of the American Heart Association, they have made comprehensive management of cardiovascular risk factors for adult with type 2 diabetes. AHA, American Heart Association 222. There's one section about lipid abnormalities and lipid-lowering therapies in type 2 diabetes. The management of this lipidemia is central to comprehensive cardiovascular risk factor control and CV risk reduction for adults with type 2 diabetes. The most commonly encountered lipid abnormalities in type 2 diabetes are related to the clustering of risk factors associated with the metabolic syndrome, including increased serum TGs, triglyceride-rich VLDL, triglyceride-rich lipoproteins, small dense LDL cholesterol, ApoB, LDL particle numbers, non-HDL cholesterol, and decreased HDL. And LDL cholesterol is often mild to moderately increased. This atherogenic dyslipidemia is associated with both chronic low-level vascular inflammation and a prothrombotic state. This accumulating clinical evidence suggests that serum TG is a predictor of atherosclerotic cardiovascular disease comparable to LDL cholesterol in populations with type 2 diabetes, which both exceed the predictive power of A1C. In patients with diabetes and ICVD or patients with diabetes at high risk for ICVD, with serum triglycerides of 135 to 500 milligrams per deciliter despite maximally tolerated statin, and addressing contributory factors including lifestyle modification, prescription icosapent ethyl at a dose of 4 grams per day as well should be considered given the 30% additional CV risk reduction in the REDUCE-IT trial. Of note, this trial, the mentioned baseline, the median baseline is LDL cholesterol in this trial was 75 milligram per deciliter, and 29% of the study population had diabetes. Several RCTs have assessed the additional impact on CV events of fibrates when used in combination with statins. Thus far, the data are inconclusive, although post-hoc analysis have suggested potential benefit in those with residual modest hyper-TG. All we know that the non-atherosclerotic cardiovascular disease need high-density statin therapy. There are several residual risks. The residual risk, cholesterol risk, residual inflammatory risk, residual thrombotic risk, and residual triglyceride risk, and residual LPA risk. But optimal control, to have effective risk management, you have to control both LDL cholesterol and TG-rich lipoprotein as a key step. At the end, we know that hyper-TG associated with residual cardiovascular risk. Genetic and preclinical studies directly implicate triglyceride-rich lipoprotein in the causality of atherosclerotic disease. The presence of hyper-TG identifies patients who require more intensive lipid lowering. Existing agents with potential to lower cardiovascular risk, fibrates, omega-3 fatty acids, are likely to be protective in high TG patients, but does not associate with TG lowering. Novel agents developed to lower TGs need further evaluation in clinical trials, but in the meantime, use triglyceride-rich lipoproteins and remnant cholesterol to serve as a surrogate biomarker. The ASC guidelines said that the prudent approach now is to employ LDL cholesterol as the primary goal and non-HDL cholesterol or ApoB as an ancillary target. As the recent discordancy analysis suggests, once the LDL goal has been achieved, careful attention should be paid to the risk linked to the elevated levels of other ApoB-containing lipoproteins as reflected in non-HDL or ApoB. This ends my presentation. I hope it will make us discuss later on. Thank you very much for your attention. Thank you.
I think Dr. Siddharthavan very beautifully highlighted the importance of not only managing the LDL cholesterol, but also the triglycerides. And very much in Indian population, specifically Asians, we have this aspect where the LDL cholesterol is very well maintained, but the triglycerides is left untamed. So thank you, Dr. Siddharthavan, for this beautiful highlights. We'll be taking your all the questions at the end of the panel discussion. Thank you.
There's a page announcement.
Well, that was a wonderful session, Dr. So we'll move on to the next session. That will be we'll move on to the next session. We should go the latest guidelines for the management of diabetic dyslipidemia by Dr. Liang Ji from China. Dr. Liang Ji is a professor, director of Department of Endocrinology and Metabolism, Peking University People's Hospital, and is the immediate past president of the Chinese Diabetic Society, vice president of Chinese Endocrinologist Association, also the vice president of the International Diabetes Federation, and he has a strong background in diabetes, focusing mainly on the epidemiological and the genetic research. Dr. Liang Ji, please take your session forward. You are on mute, Dr. Liang Ji. You need to unmute.
Thank you very much, Dr. Kumar, for a nice introduction and the chairing. I'd like to thank the organizing committee of Diabetes India and also Professor Sabu for inviting me to attend this huge congress. Now I'd like to share my screen. So the assignment to me for this session is to give an introduction on the latest guidelines for management of diabetes dyslipidemia. So I'm going to focus my talk on two parts. One is focus on LDL cholesterol, the current guidelines evidence on the cholesterol management. And then I will focus on other lipoprotein fractions of dyslipidemia. Talking about dyslipidemia in type 2 diabetes, it's really three parts. One is this elevation of VLDL and triglyceride, and elevation of small and dense LDL, and then the reduction or decreased level of HDL. All of them were shown to be risk factors for cardiovascular disease in type 2 diabetes population in the epidemiology studies. And also there's evidence from basic research that dyslipidemia, hypoglycemia, and insulin resistance, which is the characteristic of type 2 diabetes, altogether resulting a spectrum of physiological changes, which have an impact on the physiological, on the pathophysiological changes of arterial wall, resulting in atherosclerotic lesion development. And those are including the formation of atherosclerogenic low density lipoproteins, advanced glycation end products, and also the activation of pro-inflammation signaling pathways. And so far, the lipid management is an integral part of diabetes management, together with glucose management, blood pressure management, weight control, and then also in addition to the lifestyle modifications. So far, the strongest evidence are coming from the starting therapies in reducing the low density cholesterol. As has been shown from this meta-analysis, the reduction of LDL cholesterol resulting improvement of major cardiovascular outcomes, as well as all-cause mortality. This is also true in primary prevention and also in the secondary prevention of cardiovascular disease and death in the type 2 diabetes population. In addition, aiding this cholesterol absorbing inhibitors, ezetimibe, to the starting therapy, also showing benefit in further reducing the cardiovascular outcomes in type 2 diabetes population. Recently, the PCSK9, which is more potent LDL cholesterol decreasing agents, were also shown in the general population with a cardiovascular high risk, can improve the cardiovascular outcomes on top of starting therapies. In this trial with another PCSK9 inhibitors, the researchers did a subgroup analysis or sensitivity analysis by stratifying the study subject into those with type 2 diabetes and those without. You can perceive from this first plot that the effect size on patients with diabetes in terms of cardiovascular disease risk reduction is the same as in other subgroups. So indicating that on top of starting therapies, aiding PCSK9 in type 2 diabetes population also can further reduce cardiovascular risk. So based on those clinical evidence, the ADA has recommended the starting therapies for the primary prevention of cardiovascular disease and death in patients with type 2 diabetes, and also on the secondary prevention of cardiovascular disease in type 2 diabetes. It's also stated that based on those evidence, if starting therapy cannot achieve optimal cholesterol control, you can aid either ezetimibe or in the case of a secondary prevention, PCSK9 to further reducing the LDL cholesterol levels in order to increase, improved the prevention of cardiovascular disease in those with higher risk of developing those conditions. This was also reflected in the guideline of Chinese Diabetes Society, is recommended starting as a first-line therapy for managing higher cholesterol levels, and if needed, other medications such as ezetimibe or PCSK9 inhibitor can be added to further improve the level of cholesterol control. So how about other lipoprotein fractions or targets outside the LDL cholesterol? From the clinical trials aiming at reducing the LDL cholesterol levels, there's still a residual risk that cannot be addressed by simply reducing the LDL cholesterol levels, such as in IMPROVE IT study, which is a combination of simvastatin and ezetimibe, and the FOURNIER study is a combination of LDL statins with evocumab, which is a PCSK9 inhibitor. And also there are many epidemiology studies showing that the elevation level of triglyceride is associated with ASCVD. And also there are many mechanistic studies or basic research indicating that triglyceride might play a role in the atherosclerotic process that leading to the cardiovascular disease. But unfortunately, using the niacin either in combination with statins or uses alone didn't show a clear benefit in further improving the cardiovascular outcomes. The same is true for those agents that can increase the level of HDL cholesterol, because in the epidemiology studies, the elevation of HDL cholesterol is a protecting factor for the cardiovascular disease in both general population and also in type 2 diabetes. From the previous clinical studies, it didn't show that statin plus fenofibrate or fibrate study can further improve the cardiovascular outcomes, questioning the role of triglyceride lower therapy in the role of preventing cardiovascular disease on top of statin therapies. And there are dedicated trials to try to address the role of fibrates in reducing triglyceride levels on top of statin therapies, such as in the ACCORD study, the researchers didn't show that on top of a statin standard care, aiding the fenofibrate have further improved the cardiovascular outcomes. But in the subgroup analysis, the researchers have identified there's a trend in the subgroup with they called diabetic dyslipidemia, which characterized by increased level of triglyceride and decreased level of HDL. But unfortunately, a dedicated trial tried to prove this hypothesis that this diabetic dyslipidemia is a cause for cardiovascular disease in type 2 diabetes population. And this COVA trial has recently been adjourned because of a lack of efficacy. In this trial, they use pemafibrates, another agent that can reduce the level of triglyceride. And this study didn't show that aiding these agents to reducing the level of triglyceride on top of statin therapy can further reduce the outcomes of cardiovascular disease. Therefore, the ADA didn't recommend either improve the endothelin function and also have anti-inflammatory actions and also have an anti-thrombotic effect. There's also study indicating that omega-3 fatty acid can have anti-arrhythmic actions. In the reduced trials, researchers randomized patients receiving statin therapies to the placebo and then this omega-3. And the study did show that a combination of omega-3 fatty acid with statin have a beneficial effect in reducing the cardiovascular disease in the population with higher triglyceride levels. But another trial using the same strategy, the STRENGTH trial, didn't show that among statin-treated patients, the aiding of these omega-3 agents could further reduce risk of major cardiovascular events. And if we look at the difference between these two trials, and there's the effect size of omega-3 in the two trials are very similar. But what make the different in these two trials is that they use the different comparator. In one trial, which showing the benefit effect of a combination therapy, they use a minimal oil as a comparator. Actually, the minimal oil have a detrimental effect in terms of cardiovascular outcomes. As
Hello? Can I hear you?
Hello.
Oh, I can hear you now.
Yeah, Dr. Moon, it looks like there is a issue with the some issue. You're here. Can you hear me clear?
Yeah, now it's all right.
All right. Yeah. So that's good. Thank you, Mr. Linongji, for maybe we lost in the last slides, lost some words. We'll move on with the next topic. Now I invite Dr. Moon Kyo Lee. I think I spelled it correctly, Mr. Doctor, from Korea. Dr. Lee is a professor, Division of Endocrinology and Metabolism from Korea, and is currently the chair of IDF Western Pacific region and is the former chairman of the board of directors of Korean Diabetes Association and Korean Society of Lipidology and Atherosclerosis. He graduated from Seoul National University and was trained in internal medicine in endocrinology at the Seoul National University. Took his postdoctoral fellowship training at the University of California, San Diego. His current research interests include insulin resistance, metabolic syndrome in obesity and diabetes, and insulin resistance and beta cell biology. He has published over 130 scientific papers in peer-reviewed journals, periodicals, and book chapters. Yes, Dr. Lee would be taking us through the barriers and chances of diabetes management in the Western Pacific region. So he has got a systemic review to discuss with us. Thank you, Dr. Lee.
Thank you so much, Dr. Kumar, for your kind introduction. Well, I'm going to share my slide today. I'm very pleased, and it's a great honor to join again the World Congress of Diabetes India. Thank you for the invitation, especially to Banshi Sabu. And it's very nice to see Drs. Sigando and Linongji, old friends. And this time, unlike in contrast to the previous speakers, I was asked to present my original data, still unpublished. And as I belong to Western Pacific region, a neighborhood of Southeast Asia, I was interested, and I'm still interested in those situations like challenges or opportunities for diabetes management in our region. And I found we did a systematic review and got an interesting data so that I can have chance to present and share with you today. This is my disclosure, and I'm going to talk in these sequences. First, as you are well aware of, the number of people with diabetes has been and still increasing worldwide, and especially you can see those three areas the South Africa and Southeast Asia, and Western Pacific region are the regions with biggest number of people with diabetes, and are still showing the still increasing number of people with diabetes, which means a seriousness in our region, so that the investigators should be very eager to solve the pathophysiology or management in our area. And as you know, IDF launched several activities, such as IDF School of Diabetes, kids program, for example. But however, for effective diabetes education and management, it is absolutely necessary to recognize the challenges of patients and healthcare professionals, including physicians. And some years ago, I still remember a very impressive talk presented by Dr. Narayan at his Kelly West Award lecture. The brief summary is is in the center panel. So he stressed a huge mismatch between where the diabetes burdens reside globally and where the research is concentrated. So that his conclusion was the importance of investment in global collaboration in research and policy to win the war against diabetes. I think sometime will this kind of time will come to us. But in that occasion, we have to prepare such that we have to study hard as to the specific pathophysiology or patient characteristics or social conditions, etc., etc. Well, now this is a brief summary of Western Pacific region. We are also part of IDF, and WPL has the biggest area number of people with diabetes currently and in near future, and we have very diverse languages, which can be a barrier and lifestyles and healthcare systems. So that so far there has been almost no efforts to arrive at a consensus guidelines for diabetes or any kind of lifestyle related diseases so far. This is a brief summary of the characteristics of diabetes in Asians, but it's that can be summarized like a marked increase in prevalence, especially in young age groups, and the decreased insulin secretory capacity, which is similar to the southeastern populations as well, which is similar to the expression like small pancreatic beta cell mass or function, something like that. So in summary, the Asian people are prone to have increase in visceral fat mass within the same BMI, and a relatively decreased pancreatic beta cell function, which can be a dual risk factors for the diabetes, as you know. And this is our data. Some years ago, we've also published that kind of similar data that insulin secretory defects can be identified at a very initial stage of glucose intolerance, such as IFJ and GT, compared to the Western people. This is the insulinogenic index. A decrease in beta cell function can be identified at the stage of IFJ and GT. And this was also confirmed in both non-obese and obese people. So at that time, we were very interested in the beta cell function at that time in our population, which can be found in several other areas like China, Japan, and Vietnam, Cambodia, etc. And WPL region has been running a diabetic foot care project for several years, led by Professor Yutaka Seno. And they've also done many workshops and studies, something like that. And this is a very interesting summary showing that regional differences in characteristics of diabetic foot lesions compared to the Caucasians. WPL patients are inclined to show the younger age and male dominant, the no gender differences. And the interesting thing is the amputation is more common in Western Pacific populations, and compared to the Caucasians, the healthcare systems for diabetic foot care are very inferior compared to the Western populations, so that we have to be more careful about the foot care in this area. I think it seems to be similar in Southeast Asia as well. And this is data from Japan. They're showing that the most prevalent cause of death in people with diabetes are usually cited as cardiovascular disease. It is similar in Asian populations to some certain degree, but as time goes on, as you see, the vascular lesions are decreasing, but the cancer, the mortality due to cancer ranks first in Japanese people, compared to, which is quite different from that of Caucasians. And this is a data from Korea, which is similar. I mean, the most prevalent cause of death should be regarded as cancer in Korean populations with diabetes as well. And in the meantime, we've done a literature review to see the other regions' data, especially in terms of the systematic review. This is the data from South Asians. They also, your region also is stressed the important examples of barriers such as lack of knowledge, misconceptions, lack of cultural adaptation to diabetes management, which can be a sort of specific to the region. But at the same time, they also extracted facilitators for diabetes care, such as programs focusing on improving communication, misconceptions, and culture-specific strategies, which can be very plausible and reasonable. This is a data of systematic review from Latin America and Caribbean. They did very diverse analysis using the many published papers, but as a whole, the most of them are related to lifestyles and culture-specific characteristics in terms of both barriers and facilitators as well. Therefore, but we found none. Actually, no one such studies of systematic review, or if possible, meta-analysis in Western Pacific region. But as we didn't find any important studies so far, we've decided, and we've recently done a systematic review using this kind of databases such as PubMed, Web of Science, and Cochrane Library. And these are the keywords we've used for that analysis. This is the selection criteria, such as written in English, type 2 diabetes adult patients from Western Pacific region. Should be original data, not the review one or citing data, etc., etc. And after extracting the unrelated manuscripts, we collected 63 papers, and we asked two independent epidemiologists to qualify the data of those papers we selected according to the mixed methods appraisal tools and NIH study quality assessment tools, such as this is a scale that using 5 different each criteria for qualification of the data. Our epidemiologists finally they arrived at a qualification, and they approved us to analyze the 63 abstracts and papers. Yeah, this is the flow diagram among more than 80 abstracts. We finally extracted 63 studies which met inclusion criteria. And it's interesting to see that more than half of the studies were conducted in Japan, Malaysia, and China. Yeah, this is the summary slide showing challenges to diabetes management in WPL. There are we've also done extensive analysis, but the red ones can be regarded as a relatively specific, which did not show up in other regions, such as poor sleep quality and quantity, sleep duration, etc., or long working hours from Japan, and quality of healthcare. What a type D personality. I'm going to mention again briefly at a later time. And beta cell dysfunction. It's very interesting to see that kind of the terms in region specific papers. And this is the chances to diabetes management. We found such diverse class of chances for diabetes management, but I think I can say that at this moment that these are the similar. These kind of factors could be identified in other regions as well. So as a discussion point, I'd like to stress the importance of psychological factors, because there are many papers on the association between major depression and diabetes. I think you can agree with that. So as time goes on, the stresses of people are increasing, I guess. And this is the more detailed, analysis on sleep quantity and weighted mean difference in A1C, which shows a significant association. And this is the meta-analysis of type D personality. Well, I think you are well aware of type A personality, and type D personality is explained by mixture of high level of negative affectivity and social inhibition, leading to negative emotions. And this is associated with threefold increased risk of poor prognosis. And it's also associated with significant risk of diabetes. And it is still important to clinically detect the effects of type D personality trait on DM prognosis, including mortality in our region, as well as other regions as well. And this is also the multivariate logistic regression analysis data showing the importance of the beta cell function, as shown in this slide. Postprandial C-peptide reactivity index, which denotes a beta cell function, was significant still after the diverse, adjudicate the statistical adjustment. It still shows the very significant correlation with the hyperglycemia after 2 years. So I think the beta cell function could be a very important factor we have to consider in care of patients with diabetes, especially type 2 diabetes in our region as well. So as time is limited, I'm going to summary. I don't need to summarize in detail because there are very explicit but a small number of data in my presentation today. There are, as you know, there are very remarkable barriers such as the natural disasters or lack of insulin supply, etc. But at the same time, it seems absolutely necessary to control lifestyle and mental health problems, especially in Western Pacific region, in patients with diabetes. And at the same time, I'd like to say the quality of healthcare and policy should be supplemented, the management as well, according to individual characteristics such as type D personality or beta cell function, especially in people living in Western Pacific region. But lastly, I'd like to summarize the necessity of investment in global collaboration in research and policy. It's warranted, especially in Western Pacific region and Southeast Asia as a whole, Asian countries as a whole, which have the biggest number of people with diabetes, and will have the biggest number of people with diabetes in the future. These are the acknowledgements. I'd like to acknowledge the previous, the past, chairs of the IDF-WPL. Thank you so much.
Thank you, Dr. Lee. That was a wonderful research indeed. It basically touched the core reason why there is a vast difference in diabetes incidence and control in the different regions of the world. And the mismatch, like you pointed out rightly, the mismatch between where the actual area of incidence of diabetes is there and where the research is conducted. This mismatch has led to maybe there is a little bit of information we are losing as to approach the right way. For example, like you said, in the Western Pacific region also, there is the podiatrist. Yeah, sorry for that. So the Western Pacific region, the foot care, the slide which you had presented, they say the physicians and the surgeons are the major people who are looking at the foot care, whereas in the Western area, Western countries, it is mostly the podiatrists and the specialists that take care of the foot care. And probably this is the reason why there is a decreasing incidence of amputations. So that is one point you highlighted very well. And maybe this is where we need to project to the world, where there is an increasing incidence of diabetes and the complications. If we do a lot more research and understand the actual ground situation in these areas, we could be doing more probably better control in the global perspective. I think you agree with that. Yeah. So coming to the chances of diabetes better management, and it is rightly put forward by your study, the stress levels and the sleep quality, that has been the major considerations in the current situations, and the newer generations are going through a lot of these problems, and definitely this can percolate into a more incidence of diabetes in the future if it is so. So lifestyle management is what is again reascertained here in your studies, and that's thank you for that. And we have a question in the chat box. This question probably I think Dr. Linong Ji would be a better person to answer this. It says regarding the incidence of adverse event for the use of high intensity statin, which is myopathy, is an adding PCSK9 to the statin therapy could increase this episode?
Yes, I think this is a very good question. Actually, the myopathy observed in a statin treatment coming from the statin itself. It is not from LDL lowering. So by further reduction of LDL from PCSK9 inhibitors actually didn't increase the incidence of the side effect associated with the statin therapies. Yeah.
Okay. I don't see any further questions here.
Yeah, actually, I have a question to, I'd like to have a comments from both Professor Menghui Li and Professor Sequando. It's about this early onset or young onset diabetes in this region. In recent years, we have observed in our clinical practice, also from epidemiology studies, that in this region, particularly in East Asian population, and probably in also in India, the incidence of diabetes from young population are now increasing dramatically, and also in the epidemiology study showing that actually they carry a more risk of developing diabetes complications especially the cardiovascular conditions. So I'd like to first have your impression on these issues in your specific regions.
Absolutely. Thanks for the very important comments. I totally agree with you. We also have some similar data in Korea as well, showing the doubling, almost the doubling, or the doubling of the incidence in younger generation, like in 20 and 30, compared to the years of 1980 or 1990, something like that. These days, their incidence level doubled in over 30 to 35 year periods in Korea, which is very impressive and very serious, because, as you mentioned, they will live longer than the old generations, and they are more likely to have complications. And it's interesting to see that although their beta cell function is declined, most of them are type 2 diabetes, which is almost equal to the metabolic syndrome, which encompasses diabetic dyslipidemia and hypertension as well. So that their risk should be the controlled more comprehensively. But it's more complicated to administer or prescribe some complex medications to them. So the pediatricians are very agonizing to comprehensive control the younger generations of people with diabetes, I think.
I think I agree, because let's say in Indonesia, I think it's correlating with the increase of obesity. Mm-hmm. You see more and more obese children, more and more young adults, and this just because of the lifestyle. And I think this affects the increase of the incidence of diabetes.
Yeah. How about in India, Chairman?
India is again like there's no much different. We are also witnessing an increasing incidence of all these higher LDL, higher incidence of diabetes. Definitely, it's increasing. I would go with Dr. Moon Q Lee's research. Definitely, the lifestyle has been playing a larger role in increasing the incidence. I agree with Dr. Samdu as well.
But I'd like to make a short comments on this. Recently, we found a very serious situation in case of childhood type 1 diabetes. The National Health Law of Korea says that those patients, including type 1 diabetes, who should take care of multiple insulin injections and some other sick illness as well, should be appropriately taken care of at school as well. It's a very, very literally very important and explicit dictation. But in reality, the newspaper said, and the major television news reported that many of the type 1 diabetic patients, children, inject their insulin during school, at school in the behind the curtain in the washroom, because school nurses are reluctant to help them inject at the school nurse's office, because they are concerned about the potential inadvertent accidents without doctor's prescription at school. So we have been agonizing to solve that problem. So we invited the members of parliament and the patient association, school nurses association, and Korean Diabetes Association, and it was solved, after 3 years of discussion, and at last it was solved by the parliament. They passed, they revised the law that school nurses the most of the schools should hire at least 2 school nurses, and they are exempt from the inadvertent accidents during those kind of health activities at school. So I think there are very, very, if we will try, we can find easily those kind of pitfalls and barriers in everyday life around us, especially in patients with diabetes, at the job or at home or in the neighborhood.
That's true. That's true. Even in India, we have such kind of agonizing situations. But the problem here in India is each patient is taken care by themselves. No law would be helping them in such situations. Actually, like we need to take case by case to understand their barriers and then discuss and try to solve these issues case by case, because each case has got a different barrier and it can be multiple as well. So that is one of the challenges we face in our country, in India, when it comes to child, the type 1 diabetes. Coming to type 2 diabetes, motivation has still been the biggest challenge in even explaining them the need to better control and the benefits of better control, even after explaining and teaching them, showing them the evidence. The motivation still remains at the lower levels. I don't know where we need to go for, how far we need to go to strictly make them understand. Maybe this kind of approach has to be developed right from the early ages in life, so that they know the importance of lifestyle and the prevention of this kind of chronic diseases. So that's the point we see in India. Any comments? I have a question for Dr. Linong Ji. As you had gone through the guidelines of managing diabetic dyslipidemia, wonderfully beautiful guidelines has been approached. What, in your view, do you see any further more strict recommendations coming in the future to control better, for the better control of LDL cholesterol? Because even after using high statin, there are quite a few, even much more incidences of uncontrolled dyslipidemia in diabetes. Do you see any further progress in the recommendations? Dr. Linong?
No.
Sorry. Anybody
else? Internet problem.
Internet problem. Can I ask Professor Segundo to give his insight?
Can I comment? Because we should follow the guidelines. You have the American guidelines, you have the European guidelines. These guidelines are not the same, but I see that even on TGs, the Americans are the targets also. The American guidelines are less than 70, but the Europeans are less than 55. And even the goals and targets are different. Yeah, and if you but about TG, both countries or both continents are having now getting more interested in TGs. Yeah, and because the residual risk, with statins you get only 40%, 60% are still not achieved, and even with PCSK9 inhibitors, because if you use because the target with statins, if with the highest tolerable dose, that means there are many patients who are cannot tolerate statins, and for these patients you have to use either PCSK9 inhibitors or other products. But for patients with LDL not a target, but with higher TG, you still have another target. But now you have the problem of the reduced trial and the strength trial with the different Professor G said, because the target will be different, and then TG is going to be more and more what do you call it, we are going to resolve the residual risk. Because statins is very much used even in Indonesia. The highest top medicine in the insurance is statins, but still they are not used. I mean, not at the accurate dose. Some are used at moderate dose, but never used, or not very seldom to higher dose because these side effects. And for this risk, we have to take care. And I'm sure that in the future there will be guidelines, because the pathophysiology of atherosclerosis, that remnants now is going to be different, not only LDL cholesterol. The remnants are also now studied. Yeah, and then I'm sure they're going further and further. So many drugs is coming in our part. In the US, there are so many drugs. But I don't know whether it is in Korea and in China, but the PCSK9 inhibitors, the inclisiran and so on, they are very, very expensive. But can we afford it? That's the problem. Thank you.
Yeah, Dr. Linong, you have a comment here.
Yeah, I think in the future with increase of affordability and accessibility, those new agents such as PCSK9 and other injectables that can have a half-year efficacy will play a more important role, because still pills burden one of the barriers for the compliance in lipid-lowering therapies. But as Professor Segundo has nicely pointed out, the affordability and accessibility of these new agents, especially in our region, are still an issue.
Yeah. Well, I have a short question to both of you. Both Drs. Segundo and Linongji showed us the importance of diabetic dyslipidemia, especially importance of triglyceride. So, but it's it's not that easy to routinely measure Lp(a) or LDL particle number, or even the size, etc., or even ApoB. So in that case, what if you are seeing patients with diabetes and diabetic dyslipidemia who with TG level of around 400 or 210 or so? Is it what you mean? Do you strongly recommend the physicians to prescribe either fibrate or pure form of omega-3 fatty acids in addition to statins to them?
Okay.
Go ahead.
Please.
Go ahead. In the guidelines, there's such a recommendation as to aiding the fibrates or other agents to lower triglyceride in those individuals with much higher triglyceride levels, in order to prevent pancreatitis. But if you look at the literature, there's no very convincing studies showing that, of course, there are epidemiology study, a case report showing the correlation between high triglyceride and risk of pancreatitis. But there's no good studies showing that if you prevent, you lower the triglyceride, you can actually prevent the pancreatitis. I think people are still using the clinical observations and epidemiology data to guide their the recommendations. So I think in the future, maybe we can do studies on this issue to see whether lowering the triglyceride can actually prevent the risk, reduce risk of pancreatitis.
Yeah, thank you. I think we are out of time now. Thank you, professors, and we all had a very great discussion of the cholesterol. And thank you for attending this session. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye, Lino.
Namaste, bye.
Dr. Segundo.
Okay, thank you. Thank you.
Yeah.
Great. Take care.
Thank you.
Yeah.
Nice meeting
See you.
you. Tinong.
Yeah. See you.
Agree.
Bye. Segundo, Dr. Segundo.
Nice meeting you. Thank you very much.
Thank you.